Good morning. Today I am presenting case report of Mrs. Jumailith, 44 years old female patient, hailing from Tripura. She is a housewife, reported to the college OPD with the chief complaint of missing tooth in the right back tooth region of upper jaw, and she wants to replace it with fixed tooth. History of presenting illness. Patient has a history of extraction of upper right back tooth due to mobility 2 years back. This is past dental history.
Yeah, got it.
Let's go grade 2 mobility in relation to 1-1 and grade 1 mobility in relation to 2-1, 1-4 and 2-2. This is the initial photograph, clinical photograph.
Which are the teeth mobile in this case?
So 1-4,
1-4, 1-1,
2-1 and 2-2.
2-1 is also mobile.
2-2 she had already undergone RCT and crown placement.
On 2-2, that's firm.
No, that also contains grade 1 mobility.
That also is mobile.
Yeah.
So that means both the centrals and that lateral is mobile. What about tongue thrusting habit for this person?
She has got
Tongue thrusting. Deep bite also. What about molars? First quarter molars?
She has only about 1-7.
1-7 is mobile?
No, it is firm.
Totally a shattered occlusion, right? With tongue thrusting and deep bite. Okay, X-ray. Okay, this is occlusal side. That's the panoramic view. That can we read it from 1-7? That's 1-7, right? The last molar. Yeah. How is it from 1-7? How is 1-7? It's not mobile. It's firm. Okay. And the one tooth missing next to this is 1-6. 1-6. That's when was that 1-6 extracted?
2 years back, due to mobility.
2 years due to mobility.
Mobility.
Okay. 1-5.
It is firm.
It's mobile or something? No, it's firm. And 1-4?
1-4 is it has a grade 1 mobility.
And it is mesially drifted. It's rotated.
Yeah, rotated.
Can we see that clinical picture once again? The previous one? Yeah. No, next one. Not much rotated. 1-4 is rotated. Yeah, which one is mobile now in that? 1-4. That is rotated. 1-4 is rotated and it's mobile. And the one next to it is canine or lateral?
Lateral.
Canine is gone.
No, that's already missing congenitally.
Oh, it's missing.
Yeah, missing.
So that's lateral what is in there. That's grossly restricted. Only the root stump is remaining.
RCT.
RCT was attempted and it's
2 months
fractured.
back.
Fractured. And the next two central incisor and the lateral is mobile also. So right now, which all teeth need extraction? Which all teeth should be removed from this?
So, 2-1, 1-2.
And even 2-2, right?
2-2.
2-2, 2-1, 1-1. Then again 1-2 and 1-4. So the only teeth left are 1-5, 1-7, and then on the other arch you have got 2 premolars and 1 molar. What's the condition of those 2 premolars and molars?
It is firm.
Firm. So patient is chewing with both the sides? No. Lower, that person seems to have FPD on the lower. So that side person is using for chewing, not the right side. So now, if you extract it, how are you going to rehabilitate it? Are you planning for a full bore, some replacement, or only the mobile teeth to be extracted and replaced?
First total is 2-1.
Even 2-2 is mobile, right? So up till 2.2, you need to extract and replace it. You don't want to touch 1.7. Okay. And you want to leave the 2.5, 2.4, 2.5 and 2.6, you want to leave it there. So, and even that can add 2.3.
2.3 to 2.6.
2.3 to 2.6, you are going to retain the natural teeth. And even 1.7. Rest you want to extract and rehabilitate. So the best option would be definitely in this case as implant. Because you can't have an FPD anyway, since you don't have enough teeth in between. So you want to go for a fixed implant FPD, implant supported FPD. So how many implants would you suggest for this case? Considering the tongue thrusting habit, tongue thrusting is not a very fruitful thing to consider an implant supported FPD. Because tongue thrusting, though when you have a tongue thrusting on a natural teeth, there is some kind of withstanding from the periodontal ligament. But an implant will never give such a support. So an implant supported FPD means you need to have additional support which can withstand the force. Probably there's a D-bite also here. That's what we saw in the initial bite. So D-bite has to be taken care of, tongue thrusting has to be taken care of, plus this long FPD will have to be supported by enough number of implants as well. So the support of an FPD is from the implant bone interface, which should be increased. And the best way for increasing the implant bone support is by increasing the number of implants. The best is to increase the number of implants. Second would be to increase the diameter of implants. Third one, or the least choice, will be to increase the length of it. So to get maximum number of implants and maximum diameter, the best choice would be to go in for what kind of an implant placement? Because you cannot expect to have enough of width of bone on mobile tooth region. So if you allow that area to heal by itself, in a normal healing if you leave it, ultimately you will end up in very narrow range. So if you are planning for implants, then to get maximum diameter possible, it's always immediate implant. That would be the choice. Immediate implant guarantee you the minimum width of that socket, which will be almost corresponding to the width or the diameter of the natural teeth. But if you allow it to heal by itself, then the socket is going to collapse and you will not get enough of width of the ridge. So immediate implant should be the choice. Okay, fine. So how many implants? If it's 4, then which all area should be planned for it? Distalmost area should be considered if it's possible. So distalmost in this case will be the lateral and the first molar. The second quadrant is going to be the lateral and the first quadrant is going to be the last molar. That's the distalmost area of the FPD. If you can have these two areas properly fixed with 2 implants, and half your job is done. Then 2 will have to be equally distributed. So lateral, 1 immediate implant. What about the molar?
Yeah, 1.6.
That one thing we need to study. So in between another 2 implants. So let's start planning with that 1.6 first. Let's see the condition of 1.6 in bone, in radiograph. Seems to be not having enough of bone height. How is it otherwise in other conditions? IOPA. Yeah, this is the IOPA, right? So you can see a clear sinus flow projecting into the crustal region. So can we have the height availability in that region?
Sir, 8, 10 and 30.
That's leaving how many millimeters? From 7?
From the crust of 7.
No, from 7, how many millimeters away is this first line what you put?
So
Around 3? Okay, what was that first line? How much does it show? The height?
8.
8. Then?
And 10.
10. Then?
13.
13.
13.5. 6.
So it's towering. 8 to 13.
13.
That's the sinus floor. So the minimum what you can have is 8, right? So you have to consider 8 itself. Because the other 3 are like, again, just 1 millimeter apart, right? So the entire width what you have shown there is just how many millimeters distance is this 3 lines? Are these 3 lines? Down, I think there's something written there. What is that length you have taken down?
2 millimeter.
Total of 2 millimeters.
Yeah. It's 4.12.
4.1. So it's 2 millimeter apart. So that from the first line to the second line is 2 millimeter. From the second line to third line it's another 2 millimeters. That means it's 4 millimeters size. So it's the size of quite a good implant. So if it is 4 millimeter size, then the minimum height you can plan is less than 8 or 8.
8.
So anything beyond 8, you will land up in sinus elevation or into the sinus. So 8 millimeters. What about the possible width of the bone over there to decide on the diameter?
So at crust
7 millimeters. 7 millimeters is quite a good width. I mean, the width is sufficient enough to place a good implant. 7 millimeters means how many millimeter implant can be placed in 7 millimeter diameter?
2.5.
That is 1.5 from the buccal side and 1 from the palatal side. That is sum of 2.5.
4.5.
So you get 4.5 diameter implant possible to be placed here. So that means the crust is sufficiently enough. So crust is a dependable area. So from the crust, you have got 8 millimeters. At 8, I think it is already into the sinus. 8 shows to be almost into the sinus. So what we can have here is probably 6.5 or so. 6.5 or something you can encounter sinus. Anything beyond 6.5 you might encounter the sinus. Okay. So will a diameter of 4.25 into 6.5 be sufficient for this FPD? You want to increase the diameter or the height?
Height of the.
So you are okay with the diameter, 4.25 is fine. So 4.25 into 6.5 is not a very comfortable size of an implant. So you need to increase it to what level?
8.
What height?
4.25 to
8. 8 or beyond?
8. Beyond.
Anything beyond 8, anything beyond 6.5, if it is 8 also you are happy. So 4.25 into 8 or even 10.
10.
Okay. So the only way out is implant, sinus lift, right? And 5 need to be extracted. Is it okay if you place one as an immediate implant in the socket of 5? Because anyway 5 has to be extracted. No, you want to replace that 6, till 6 you want to replace. Okay. So sinus lift. And the other implants will come somewhere in 4 or the lateral or central region. So we'll focus on this one implant right now. So how do you plan for the sinus lift? You've got a comfortable drilling sequence, you can go up till what level?
3.
No, up to 6.5 you can comfortably get drilled into, right? You can drill up to 6.5. So you can go up till 6.5, the drilling sequence. And your implant size is 4.25. What density do you expect in this case? That was a tooth that is being extracted for mobility reason, not because of dental caries. It was mobile. So seeing the trabecular pattern and the history of being extracted for periodontal reasons, the density will be definitely less. It will not be as dense as any other region. So it can't be in the D1, D2 region, not in that character. It could be D3 or even D2, D3, but definitely not a very thick one. So do you want to go in for your last drill and then place implant, or one drill short? One drill or two drills short, according to how you feel the bone. So 6.5 is fine. So since you're planning in for a diameter of 4.25, whatever you choose, how much ever long you drill, the drill has to stop at 4.25 is your implant diameter.
3.5. 3 to 3.5.
Which all drills do you have?
2.8.
2.8, then 3.
3.
Then
3.5.
3.5. Then 4 and
5.
5. So 4 is not a pro choice.
3.5.
3.5 you have to stop. So 3.5 is the maximum possible drill for this case. So 3.5 into 6.5. I mean 3.5 diameter into 6.5 length, you can go in for direct drilling without any problem or issue. But you have to be very careful with that drilling sequence. So once you start off with the initial drills itself, take an X-ray and confirm you are not
Close to sinus.
involving the sinus or something. So you start with the lance drill with a position. Do you want to extract the premolar and then start the procedure, or do the implant and then extract the premolar?
Extract.
Yeah, you can extract. We'll get better access to that area as well. So both the premolars?
5.
Only 5. Okay. So extract 5 and start off the procedure. So once you extract 5, what kind of an incision will you do to open it?
Circle.
Same H incision. So premolar is extracted. Right from the crest of that socket region, you put an incision up till 7. Okay, anyway, 7 is mesially slightly migrated as well. So that's going to be till 7, then completing the H over there, then open the flap. Confirm this 7 millimeter of crust that you have to confirm. So once you have confirmed, then which position will you place it? Since you are planning to leave that 7 in the same place,
1.5.
yeah, how many millimeters away from it? 1.5 should be from the contact area. That seems to be mesially migrated. So that undercut has to be added to it. Not 1.5 from the cervical area. From the cervical area, how much is the undercut? That has to be added. Then position it from the CEG. So that seems to be, looks like having around 1 or 1.5 millimeter from into that undercut region. That can be assessed only from the cast. So where's that model? Yeah, I think you have shown the photograph also in that. Yeah, this model, you need to assess how much is the undercut of this region. How will you do that? Yeah, place a flat instrument exactly corresponding to that migrated 7. So you'll get an undercut underneath it. So that has to be marked first. That region has to be marked, and that area of undercut has to be calculated. You have to add another 1 or 1.5 along with it. So that means if it is 1.5, you have to add another 1.5 to it. That makes it 3. So once you open a flap, your position of the implant, the outer diameter of your implant should be 3 millimeter away from it. So the outer diameter or the outer frame of your implant should be 3 millimeter away from 1/7, cervical region of 1/7. So from there, where will the position of your lance be?
4.25.
3 millimeter away is the outer diameter of the implant. It is 4.25. 4.25 is your implant diameter. Right? Diameter of the implant is 4.25. The radius is
2.2.
Take it as 2.5. 2.5. So 2.5 plus 3.
3.
Am I right?
Yeah, 5.
So it has to be 5.5.
5.
Since you're extracting that premolar, you've got lavish area over there. So it should be 5.5 or 6 millimeter away from the 1.7 cervical region. So in the cast, you will measure it and confirm how much is it, whether it is 1 or 1.5 or 2. That has to be added with the radius of the proposed implant. There comes the lance drill. So the lance drill should be started from there. And the purpose of lance drill is to know the
angulation and position.
yeah, exactly. So the position and the angulation. So you can go maybe up till how many millimeters into it?
3 or 4.
At 6.5, you will encounter sinus flow. So the maximum possible is 5. 4 or 5 millimeter you can enter into that crystal bone. Then we need to take an X-ray and confirm for the position. Position is anyway you have fixed it. Angulation. Angulation of it. Then what's the next step? If everything is fine, if it seems to be okay, then what?
Go for the next drill, pilot drill.
Pilot drill. How many millimeters of pilot drill?
6.5.
6.5. You got a stopper, right?
Yeah.
So you fix a stopper to your pilot drill and go till 6.5. Okay, then definitely X-ray. Definitely X-ray to confirm it. So how many more millimeters to reach the sinus floor has to be evaluated. If everything is fine as per what you have shown here, then it should be somewhat short of the sinus floor. Little bit short of it. Maybe a 0.5 or 1 millimeter short. Yeah, okay, fine. So it is 6.5. Then what's next? 2.8 with the stopper, 6.5, then
3.
3.
Then 3.5.
3.5. Yeah. But here we need to know the density of the bone. If density is still less, then don't take a risk because you're going to go in for a sinus lift. So the primary stability will be only from the surroundings, not from the apex. Right? Since you are attempting a sinus lift, there will not be any primary stability from the apical region. So the primary stability has to come from the surroundings. So it's better that you keep it one more drill less.
3 millimeter.
Stop at 3.
3.
Stop at 3. If everything is okay, you can still go in for a drill, right? But if you go in for a 3.5 drill, and if the density is less, the final implant might not get the enough primary stability as what you desire to get. So let's fix it as 3. So 2, not 2, the pilot, then 2.8, then 3. Stop it there. So once you reach 3 into 6.5, what's next?
Split. Expansion.
Oh, you mean the osteotomes. You want to go in for a sinus lift with expansion and lift. Okay, which all osteotomes do you have? Which are the sizes of these?
2.2 into
2.2, then next one?
2.7.
2.7, then?
3.2 to
Yeah, we have already reached 3. So the other 2 is of no choice now. So this, which is the third one? 3?
3.2 to 3.7.
3.2. 3.2 can be used here. Okay, for both purposes. To widen the osteotomy site and to raise the sinus. So how would you fix that tip of it? Can you zoom and show how it is? Which is the third one? Yeah. Yeah. So that has to be fixed to what height?
6, 8.
You want to raise it till 8. Okay, 8 is fine. See, if you have raised the sinus floor any amount, then the length of that implant is your choice. Once you have fractured the sinus floor, you can even place another 1 millimeter into it. It will not harm you much. Do you understand this point? Once you have broken the sinus floor, then you can go place 1 or 2 more millimeters of this implant. Because this is indirect sinus lifting. Right? So to fracture that sinus floor, what should be the minimum height adjusted in this?
8.
Because it's already 6.5. So you fix it as 8. Fix it as 8, push it into the sinus, then mallet it with the hammer. Yeah. Mallet it so that the sinus floor will be broken, and then you will get an entry into it. So there stops the entire process with 8. Got it? So it will become a height of 8 plus now. Because it's already, floor is broken. So it is 8 plus. 8 plus anything. If you go in for 11.5 or 13, you will tear the nidorin membrane. So how much of the lift is possible? How much of lift of sinus floor is possible with osteotomes? I think you had some meta-analysis. You can go up to 4.62 millimeters, right? So since you are attempting on a molar side and the diameter is only or rather it's 4.25, do you want to limit it to 8 or go to 10? 10 means 8 plus 2. What you, from your measurements, what was seen is the floor is at 8 millimeter, or it could be 1 millimeter less, consider it as 7. So you need to go in for plus 3 millimeter. Plus 3 means 10. So you want to go in for 10 millimeter long implant. And it is suggestive that if everything is okay, then you can still raise it of 4 to 4.6. So consider both the implants, 4.25 into 8 and 4.25 into 10. You should be having both the sizes implants with you. So the drilling sequence will be 3 into 6.5. Then with the osteotome, you are going to raise it up to 8, 8 only. 8 with what is the diameter? 3.2
to
3.2. So with 3.2 you're going to raise the sinus. So that means right now the osteotomy site is 3.2 in diameter, and the length is 8 is possible, or anything beyond 8 is also possible. Okay, now what's next? 3.2. Your implant size is 4.25, so around 1 millimeter of diameter. So I go and place it directly or still enlarge it with another osteotome? You got another osteotome next after this. What is that?
3.7 to 4.2.
So 3.7 is there. So if you want to increase the size, compressed it to the surroundings, you can use that fourth osteotome as well. That will enlarge it to 3.7. Still you can have an implant of 4.25, but it's better that you stop with the previous one, the third osteotome, finish off the raising, going for placement of implant. So with that 3.2, you need to place 4.25 implant. So 8 or 10 is the question mark. We'll fix it as 8. If everything works out well, 10 is also possible. Since you're going to place 4 implants in that region, wherein you're planning to replace 70, 6 to lateral, 6 to lateral. So that means 8 teeth. 8 teeth with tongue thrusting. Minimum 4.
4 implants.
Minimum 4. Minimum 4. So that's quite a good amount of support as well. So what you need to do is plan up everything. So extract 5, H incision, confirm the crust, position and angulation with lance drill, then 6.5 with the stopper of pilot drill, then 2.8, 6.5, 3 into 6.5. With the pilot drill again an X-ray to confirm the height, then go up till 3 into 6.5, then osteotome with sinus lifting.
3.2.
Yes, 3.3 into 3.2 into 8 millimeters, then implant. Okay. Okay, let's see how it works out.